I'm Dr. Allison DiPasquale. I'm a fellowship trained breast surgeon, and I am part of Learn, Look, Locate for the information, the knowledge that goes out there to you as the patient, family members, the support system. It's pretty amazing. I got involved in this after meeting Cynthia, who's a remarkable woman who has been through her own journey and wants to inform other patients and build a network of support out there. That's a network that's truly vetted by doctors as the backbone to this webpage and this social media connection. So I'm very honored to be part of Learn, Look, Locate, and I am helping out with the genetics page. Genetics is so important and not talked about enough when we talk about breast cancer. It's so important to talk to your doctor about all different types of cancer in your family, no matter if they're related to the breast or the ovaries. Some patients come in and say, I have no family history of cancer. And then I talk further and they have got a history of pancreatic, thyroid, colon, ovarian. Lots of other tumors and cancer sites can be linked genetically to breast cancer. And not every patient is going to express that certain cancer gene. So it's so important to be very comprehensive when you meet with your physician to talk about all cancer types that are out there. So bringing forth this genetic page is just bringing forth knowledge and power to you as the patient, a previvor, a survivor, anyone on their journey to just take control of their genes and get more knowledge and how to prevent things from happening instead of waiting for them to happen.
Wow. What can you say to everyone about the fact that genetic testing is just not out there? Obviously I'm so about education. When you meet somebody and they come in and they're tested BRCA, and like on a personal note, I have a lovely follower, 36, dying BRCA, literally on her last month. So, I talked to Rosen about this a lot in the sense that this can be prevented. So talk about prevention in breast cancer and how genetic testing is one of those aspects that we can get at, as far as take control of your genes. But how do we do it? The world is, I was stupid. I didn't know. And I'm Jewish. I have a higher propensity.
Yeah. No, I think it's so important to just keep genetics in your forefront because people before you have gone through cancer care, they've given you the steps to try to figure out what genes and what mutation could be out there so that you yourself can help prevent cancer. It's so important to know that there are preventable cancers out there, and there's higher screening for cancers that can't necessarily be prophylactically removed, meaning taking that organ system out before it becomes cancer. So case in point, the BRCA mutation. We all know breast and ovarian is linked together, and that you can do prophylactic mastectomies or remove the breasts. You can remove the ovaries after you've had children. So there's lots of different things you can do to prevent it. But a lot of people don't realize that prostate's part of it, pancreas is part of it, melanoma is part of it. And you can't obviously remove your whole skin or your pancreas. So that leads you down a path of increased screening and detection. And this is where we talk about early detection is key. So genetics does not always mean to patients that you have to remove something. And patients come in very nervous about the results because they don't want to go through surgery unnecessarily, or they do want to take control of their genes, but they're just not ready to yet. And that's not 100% what it's about. It's about the knowledge. It's about knowing what your mutation is and what your risk is for you. And that way you can increase your screening. Yes, you can do prophylactic measures if you want, but if not, at least you are getting it at early detection.
Love this. Do you think it's okay to talk about, as we talked before the call, I'm an Ashkenazi Jew. So the minute I got diagnosed, it was like they ran me through the millet of, all this testing. And I think it's important that we talk about the higher risk and the lack of education around that. And then I do want to talk about the fact that although I don't have it, my sister and my cousins, they don't think they have it. So just because the woman that I told you about that's dying has an identical twin, the identical twin has it, but the older sister doesn't. So it's really important how unique this can be. So two questions, I guess.
Yeah. So no, I think genetic testing can also be misconstrued too as well, where you're saying, well, my sister got tested and she was negative, so I don't need to be tested. Well, it doesn't, genetics don't work that way in terms of the genes that we're talking about. The genes actually get passed down from the mom and the dad. So you get a 50% chance of getting your genes from your dad, a 50% chance of getting your genes from your mom. And they may not have expressed the mutation because we live longer nowadays and your mom or dad may not still be alive and they may have passed of natural causes earlier than what is normal, considered normal nowadays. And your sister may not have a mutation, but she may be the 50% that did not get it. So if your parents are not alive and able to be tested, you have a 50% chance of getting a mutation if there is one further up. So all I'm trying to say is if your cousin or your sister or someone who is not your mom or dad has been tested and they're negative, that does not necessarily mean that you do not need testing. You still need to vet with your genetic counselor your whole history of all cancers in your family and figure out which test would be correct for you.
What is a genetic test? How does it work? I didn't even
So
know.
yeah, so a genetic test is simple. We can do saliva, we can do blood. Blood typically is the more standard of care in the medical community where we can actually draw blood, check the DNA. We send it to different companies, and these different companies then now run your DNA to see if there's any genetic mutation. So it is a quick, easy blood draw, just like you would do to get your labs at your doctor's office. And in fact, most patients, if they do not have access to that, if they cannot get to a physician to get their blood drawn, the companies that are out there, including Myriad, can send it to your house where you can actually get a saliva kit. Now, it's important to distinguish that genetic testing from like a 23andMe test or an ancestry test, because these ancestry tests do not have the ability to run the full genetic panel that the main genetic companies do. So I always say, yes, learn about your heritage, your ancestry. It's so important because different ethnicities have a higher risk of different types of cancer. So knowing that is important, but talk with your doctor about the genetic test for you, because again, even if you can't get it through a blood test or you can't go into the hospital and you're doing this over telemedicine nowadays, they can simply send a kit to your house and you can do a saliva test, but it's through a different company, a vetted genetic company that looks at the DNA, the RNA, and these mutations that occur.
Do you think genetic testing should be done with your gynecologist?
So genetic testing, I just think needs to be done. It doesn't really matter where it's done as long as there's genetic counseling associated with it. So what that means is a lot of people will go to their primary care or the GYN and get the genetic test. And if it's positive, that test needs to now be counseled. What does positive mean? And that's where you get slipped in with a genetic counselor or a high risk breast clinic like I run for my patients. But it doesn't matter where the testing happens. It's just what do they do with the results of the testing. There are also a lot of variants of uncertain significance that we are finding. And that means that in the medical community, we do treat you more as a genetically negative patient because you don't have a mutation that is definitely linked to a cancer. However, there is a certain subset of patients who have a very, very, very strong history of breast, ovarian, pancreatic, and then have a variant of uncertain significance in the breast cancer gene. Now, that is a different scenario. Well, I would take that patient in my high risk clinic because I do genetic counseling and say, I know that we have a variant here and it's not pathogenic, meaning it's not linked right now to breast cancer, but based off of your family history, you are someone who I would treat almost as a positive mutation. And so we have to look at these a little bit different. And that's why with these variants of uncertain significance or positive tests, they just need to be plugged in with a genetic counselor or a high risk clinic to have further discussions about their actual risks.
Wow, this is so interesting. What about someone who gets that positive result and the anxiety and fear and the decision to remove your breast?
So if you do get a positive result, I just look at you and say, wow, that's so powerful. You have so much knowledge, not only for yourself to prevent or early detect anything for yourself, but also for your children and everyone else below you. You now have the ability to save people's lives, including your own. So I always counsel patients on that power they've gained from that knowledge. And yes, it can be scary. And patients may not be wanting to remove their breasts or their ovaries or do these drastic surgeries up front, but that knowledge has now plugged them into a system where they will get early detection every 6 months, adding in MRIs, different types of screening mechanisms to ensure that if they do get a cancer, that it's detected so early that it's inconsequential to them. So that is why it's so important to do the genetic testing. And even if you're scared of the surgery, please go into a high risk clinic, go see your breast surgeon, follow closely, because knowledge is power and you have the ability to save your life and all of your family's life.
What would you say to women living in very rural areas that do not have access to all of this, do not understand this, do not know about it? The lack of information. I share this with you because Dr. Patel, when I interviewed her, she's very into social media like you, and she brought this up. She said she likes the fact that social media can educate people no matter where they live. If they don't have access to someone like you, right?
Mm-hmm. Well, I think if you're in a rural area and you have a strong family history, it's just as important as someone who has access to all these, high risk clinics. Again, knowledge is power. So nowadays with social media, telemedicine, we are able to reach people that couldn't be reached in the past. And again, it can come right to your house, a saliva test if you are unable to go in to get a definitive blood test. And that genetic counseling now is offered online. You can get access to screening and different areas where maybe you have to drive a couple hours into a metropolitan city to get the tests, but that's once a year, once every 6 months, and you just plan them all together. So that is where the power of the internet, of telemedicine, of social media has gone to reach patients, and it's amazing. So I personally feel that genetics is not talked about enough, is not promoted enough, but I feel that the primary care physicians, the GYNs, are starting to get more involved, looking at patients' history. And another area that's getting more involved and that I promote full-heartedly is the mammogram unit. So is your radiology, is where you go for your mammograms. There are certain ones across the country now that are promoting high risk and what that means. So you actually get an iPad when you come in, or you fill out a questionnaire, and it calculates your risk score right then and there. And if it puts you at greater than a 20% lifetime risk of breast cancer based off of the questions that you answered, you are automatically put into a high risk screening program where you meet with that physician right away, the breast surgeon who follows you. At that point, genetic testing could also be obtained. So I think that there are multiple touch points throughout a patient's journey. And we just need to spread the knowledge on how important genetics is and ensure that you as the patient start to take control of this. You have the ability to ask. You can ask. Insurance covers it in majority of cases. And just ask your physician. The fact that you know is very powerful.
Talk about the BRCA gene. What's the difference between 1 and 2? And how we would never know that we have it because it's nothing we feel like cancer. I never knew, right?
Yes, so the BRCA gene is one of the most popularized genes that are out there in terms of a genetic mutation. The BRCA1 and BRCA2 are slightly different. They just have different increases in either the breast or the ovarian. And actually, BRCA2 is also related to male breast cancer a lot more than BRCA1. BRCA2 patients are also known to be more ER positive, estrogen receptor positive tumors. And a lot of the triple negatives can actually be more of the BRCA1. There are lots of different differences between the two because they are still on the similar type of gene. So these can also cross-react. So it's not hard, fast measures of if you're this, then you're BRCA1. If you're this, you're BRCA2. But BRCA2 does expand into the melanomas. Both have a risk for pancreatic, ovarian. So again, if you are diagnosed with either of these genes or any genes, if you have a positive mutation, getting that genetic counseling is beyond important for you. And that genetic counselor is not just going to look at your gene and the questionable risk factors that you have that comes printed out in the paper. They're going to look at your family history as well and say, okay, based on the fact that you have a sarcoma in your family, we're going to get you into this screening. Or, yep, there's pancreatic. You need to be in a pancreas screening program where you get MRIs and upper endoscopies. So each gene does have a different phenotype, but it's not hard and fast rules. It's very blurred lines. And that is why a genetic counselor is so important to ensure what your personal risk factor is. There are different companies out there, including Myriad, that are starting to look at ethnicity and adding ethnicity in to these mutations and saying, okay, instead of a 30 to 80% lifetime risk of breast cancer, you have more of like a 40 to 50% chance. So they're adding in these ethnicity SNPs into different gene types to give you a more focused risk score.
This is great. How old should you be when you get genetic testing? When should you get genetic testing?
Genetic testing is a very powerful thing, but you also have to be able to handle that power and that knowledge. So if I have a patient who has a mutation and she's young and she has children, they always ask, when should my children get tested? Because the fear is that they would pass this gene down. Now, it is 50-50 chance for each child. And some children, offspring, have 0 mutations in it. But what's important is not for that patient, meaning that person who actively has that gene, they want to know for their kid right away. It's what that kid does with that knowledge. So I always recommend at least 18 years old, but it depends on when and what type of gene it is and when the cancer occurred in the family for the testing. But you want that patient to really understand what that means, because if they do have that gene, they're going to be plugged into high risk screening, and they're going to start, let's say that's a BRCA mutation, they're going to start their mammograms, and ultrasounds early. Mammograms aren't very helpful in very young, 18 to 22-year-old breast tissue. So now you're going to add in MRIs. And MRIs are great, but they can also pick up a lot of benign things, creating a lot of anxiety, a lot of extra biopsies. So I always caution patients, even though you want that information for you, think about that child who has to take on all of that knowledge. 18 plus, 20 plus, even 25, based off of when that first degree relative got cancer should be discussed with your physician.
Aside from BRCA1 and BRCA2, can you name some of the other genes that people should be, aware of that are, I'm looking at the PALB and the CHEK, at least just mention them,
Yeah, so we all focus on the breast cancer 1 and 2 gene, but when you get genetic testing based off your family history, we're usually running a very large panel of genes. There are lots of other genes that you may not be familiar with, including the PALB2, the CHEK2. The CHEK2 is very unique because even though it does have breast cancer in it, it does not have the ovarian. So even though it's on the lines of the same BRCA2, like the PALB2 is, it doesn't carry that ovarian cancer risk. So there are lots of other genes that are out there. ATM, there is STK, there's different ones that are related to thyroid, papillomas, Lynch syndrome, and colon cancer. So there are a ton of genes that we look at on this panel. And again, this panel is tailored for you so that you get the correct genes tested. Now, there is a giant panel that you can do, just kind of a gamut if you kind of cover all spectrums of all of the cancer genes. That is also run as well. So your genetic counselor, your doctor will run this test, and then the company will then help counsel you on what these mutations mean.
One last thought, and then go swimming. I'm so grateful for the time. Is there anything you'd like to say as for somebody watching this overall, just in the world of what this is and what we're trying to do here? Kind of that heartfelt, like, really.
For anyone watching today, I just want to say I'm proud of you. You're on this journey, no matter what this journey is, a friend, yourself, a relative, previvor. I'm just so proud of you for being here today, getting the knowledge to take control of your genes, to take control of your life, help people, and save lives. So thank you for joining us. One thing I would like breast cancer patients to know, or just patients in general, is that your journey is unique to you. A lot of patients come in with this set mindset of, okay, I've got cancer and it's going to be just like my church member or my friend or my mom or my sister. Each individualized cancer is so unique to you based off of so many different things. When you meet with your doctor, come in with a list of questions. I always talk about, the giant things to ask. And the main things are, my tumor receptors, my stage, is it ductal or lobular, lymph node involvement, multifocal, meaning in different areas. You want to know, do I need other tests like an MRI if you've got dense breasts? Or if it's invasive lobular, you definitely want one because it can be very insidious on conventional imaging, and you want to make sure that you're actually getting the full extent of disease, as well as it also can be bilateral. So that is just a snippet of things that we talk with patients about on their first visit. Their visit's usually about an hour for their first journey down to learn about breast cancer, because everyone comes in with a different mindset. Either they know everything because they've read on the internet, or they really are just coming in knowing nothing. And it doesn't matter. I've had physicians, doctors, breast cancer doctors come in, and I have the same conversation from start to end with them because their journey is so unique to them. So starting out with all those answers of what type of cancer do I have, that has about 12 different answers to it. So taking those notes, understanding your treatment plan, individualized for you, and also ask questions. If it doesn't make sense, if you don't like what you're hearing, or you don't know if you agree with that doctor, it's okay to get second opinions. Second opinions are important. It's your body, it's your choice. You decide.